Good afternoon, everyone, and a very warm welcome to today's Ask the Expert session on the topic Dispelling Myths and Misconceptions to promote IVF access for women with fertility challenges. I'm Rashika from Pair Academy, and this session is being organized under Women with Wings, our women's health initiative, with the aim of creating a trusted and supportive space where individuals and couples can access accurate, evidence based information about fertility and assisted reproductive treatments. Fertility challenges can be emotionally, physically, and financially demanding. However, the journey often becomes even more difficult because of stigma attached to it. Today, we will explore the challenges faced by women, experts, patients, both women and men, clarify when fertility is necessary, and bust myths and misconceptions surrounding infertility and IVF. So before we begin this session, it's my privilege to introduce our expert speaker for today, that is Dr. Sonia Malik. Dr. Malik is the Chief Clinical Mentor at Nova IVF Fertility and the Chairman of Nova Southend Fertility and IVF. She is a distinguished obstetrician, gynecologist, and a fertility specialist with more than 3 decades of experience in reproductive medicine and has conducted over 10,000 assisted reproductive technology cycles. Dr. Malik has served as the president of the Indian Fertility Society from 2014 to 2016 and as the chairperson of the Foxy Infertility Committee during the same period. In recognition of her contribution to reproductive medicine, she has received the Indian Fertility Society Lifetime Achievement Award in 2024. So I would encourage all of the participants to make the most of this opportunity by listening, engaging, and sharing their questions. Questions from the participants can be shared in the chat box. And we hope that today's session helps participants feel better informed, reassured, and empowered to make timely decisions about their fertility and reproductive health. Thank you all for joining us. And I would extend a very warm welcome to you, Dr. Malik, and invite you to begin the session.
Thank you very much, Rashika. Thank you very much to the organization for having me here today and for this specific topic, which is close to my heart. I have been practicing only infertility for the last many years. Thank you, Dr. Ratna, for kindly choosing me to start with this session today. Thank you so much for this. Without wasting much time, let me again try and share my screen with you all. 1 second. Yeah. Yes, this is yes. Now, is it visible, my screen? Yeah, I think it is visible now. Is it visible? Please, somebody tell me. Yes?
Yeah, it's visible, but you will have to go to presentation mode.
I'm making it. So I think, so the topic for today is essentially, we are basically talking about IVF, and we will take a bit of infertility as such as well, not just IVF, because basically you may not be requiring IVF. Let me first welcome all of those who are attending this session today. We welcome you all, and I think as Rashika also said, and as I think Dr. Ratna would want us all to also say the same thing, is that we want you to understand what is infertility and essentially what is gone wrong with you, and then to actually dispel some of the myths that you have in mind about this very beautiful procedure called IVF. So let me take you through the first slide now. If you look at the epidemiology of infertility, and if you try and see why this is happening, then you will understand that, that it is basically there. This is a WHO statistics which tells us that about 17% of adults across the world are suffering from this problem of infertility, of not being able to conceive. And that means it accounts for about 1 in 6 couples around the whole world, which are essentially affected by this. And if you translate into our population, because basically India is a populous country, contrary to what we are talking about today, it is 27 to 28 million. That means it is about 12 to 15% in India. And therefore, we are looking at a huge load, or a huge number of people who are actually troubled with this problem and who are actually struggling to have a child. So then we come to 1 second, what have I done? So then if I look at my slides again, I've lost my slides. 1 second, what have I done? 1 second. I'm sorry for this. I'm sorry for the confusion. Let me just share it again. Are you able to see the slides? No.
Yeah, we can see them.
मेरे को नहीं दिख रही है अपनी slides, कहाँ गई? Okay, 1 minute. This is some funny thing that is happening. Zoom में तो कभी problem ही नहीं होती है.
Probably minimize हो गया होगा.
हाँ, शेयर कर रही हूँ, फिर से कर रही हूँ. मिनिमाइज हो गया, पता नहीं कहाँ से हो गया फिर. या आ गया, अब आपको दिख रहा है? कैन यू सी माई?
हमको तो क्लियरली दिख रहा है.
अब दिख रहा है, सबको दिख रहा है. ओके, सॉरी. Yeah, so here basically the only thing is now what is bothering us. What is bothering us now is that the total fertility rate, that means the total, this TFR is something, is a term which has come up very recently and which you all should be aware of also, because this actually tells us what is happening to the country or what is happening worldwide. You must have heard that the population in the Scandinavian countries and in the European countries is going down considerably. And we don't think about it in our country because we are a very populous, we have too many people here, but and so we don't understand that something is happening to our fertility rate also. But if you look at our own data of the National Fertility Council of India, then it states that about, it is at 2. This is the value which is given every year to the number of patients who are conceiving. So this is basically, it is showing a value of just 2, and the cutoff is actually just 2. That is what it is. And if it goes beyond that, below that, then there is a problem in bringing it up. And in the urban population, it has dropped to 1.9, and some of the states like Sikkim, it has gone down even further. That means that the number of couples who are married in 1 year, out of them, very, very few people are conceiving, and it's going downwards. It is a downward trend. It is a slightly better situation amongst the rural area, because instead of 2, it is 2.4 over there, still recoverable. But when this TFR, total fertility rate, falls below 2, then we are really worried, because basically what it means is that we are not producing a healthy young population. What we are having is people who are already with us, and they are growing older. So that if you see the population pyramid anywhere if you have seen it on the net or anywhere, or have a look at it on Google now, once we know about this, if you look at the population pyramid of India is still good. We have lots of young people at the top, and the base is very, very good for us. On the contrary, in the countries, people on the contrary, if there are people where there is a lot of aging, it is an inverse pyramid, then it means that basically the population of that country is more aged, and that becomes a burden, economic burden for the country. Hence, this figure is very, very important now for India as well, and for all of us as a country, and especially for those patients who are actually suffering from this problem. So then, if we go on, what is gone? The slide is not moving now. Oh God. कुछ ना कुछ हो जा रहा है. अब क्या करूं मैं? अब ठहरो, इसको फिर करूं अब शेयर. I'll have to start sharing again. तभी होएगा ये. Something is wrong. Yeah. Okay. So essentially now what we need to understand is, why does conception fail? Now, here are listed some of the causes which you all probably know, or some of you who are actually suffering from the problem may actually be having it, So essentially, WHO has defined infertility as a disease, and these are the female causes of infertility. One is that the ovulation is somehow affected. You may not be ovulating at all, or you may be having a low ovarian reserve, which is what we will discuss about gradually, or basically you may also have no ovulation at all. That is called anovulation. When you don't have any ovulation, it is called anovulation. When the ovarian reserve is less, then you may have ovulation every other day, every other month, or you may have ovulation after 2-3 months, or none at all. So essentially, all this can lead to infertility. These are the ovaries over here, and this is the tube, and these are the tubes These are the tubes which enter which are opening close to the ovary, and they pick up the egg, and then the sperm comes in from the uterus and fertilizes in the tube. So that is how this whole thing takes place. Fertilization takes place here in the tube, and essentially then the baby comes and rests in the uterus. So the first thing that is important for us is the ovulatory function then. So this is what happens when there is anovulation or diminished reserve. Then you have tubal patency. That means the tubes are not normal, and they are either blocked, or they may be diseased, they may be swollen or anything like that, and so they have to be also assessed. Then you have problems within the uterine cavity, because that is where the baby is going to rest. So if you have fibroids, so if you have something called polyps, or if you have some bands inside or something filling up the uterus, then basically the baby doesn't have enough space to first settle down in the uterus and then grow within the uterus. So therefore it is very important that the uterus also should be normal in order to have a pregnancy. Then of course we come to the male factor. Now, in the male factor, according to WHO, the count has to be good. We'll come to it. The motility, that means the moving sperms in the male, have to be many, and then also that the shape of the sperm also has to be correct. So all this has to be assessed when the patients come to us. So these are the common factors, but the most important and non-negotiable factor is the female age of the female partner. This is something that you all have to remember, because what happens is this is something which is not going to change. We can give you medicines to start the eggs to produce more eggs from the ovary. You can have that. We can correct the tubal patency. We can change. We can also correct the uterine cavity to a certain extent also. But again, male factor is a difficult problem also that can be corrected, but the age of the patient is basically fixed and it's not going to get corrected. So you have to remember that as you age, the fertility starts to fall. And unfortunately for us in India, what has happened is that we have done studies, and there has been a very nice study from India, which was done a couple of years ago, and it was a comparison between the Spanish women and the Indian women of the same age. And what we found was that the Spanish women are more young as far as their fertility is concerned. The Indian girls were aging at a rate of 5 years before the Spanish girls. So if you are 35 years of age, then essentially, if you compare yourself with the Europeans, you are 40 years according to their age. So that is why our aging is advanced. We are advancing in age. Hence, you have to be very careful, and that means that you have to start thinking about fertility at a younger age, because at an older age it is going to give rise to poor pregnancy rate. That is a very important point for us to understand. Here again, if you look at the etiological and here we are trying to describe to you the male factor. Male has always been ignored, because in India, in our culture, it is always the woman who has been said to, because the baby is resting in the uterus, so nobody understands that the male contribution was also a lot. And so essentially, it is now very recent that the males have also, we have started acknowledging and talking about the male factor as a major contributor towards infertility. And you can see over here, these are WHO statistics which tell us that the male factor as the only reason for infertility is in about 40 to 50% of the total number of patients we have. Female factor, on the other hand, is about 30 to 35%, and a combined or unexplained, that means both male and female combined, or there may be patients where you may not be able to determine what is the cause. This is again about 25 to 30%. So therefore, the clinical implication of this thing is that you cannot just leave the male at all. When the couple comes to you, or when you are yourself having a problem, just don't think that it is you. Your husband also has to have a initial evaluation and a clinical examination and a semen analysis, so that we know exactly where the problem is. Now, here are some of the indicators for you. These are from the WHO guideline again, which tells us that the volume of semen, the lower limit for that is 1.4 ml. And if it is very little, then again it is not good. But if it is very high also, suppose you have a volume of about 3 ml, that also is not good. There can be a pathogenic cause over it, or there may be a cause of it. probably infection somewhere, but then that definitely needs to be looked into. Again, the concentration, or that means the total number of sperms within the total semen that has been given to us, should be about 16 million per ml. So if it is 1.4, it should be about 20. That is what it is. That is the lower limit. And of course, anything above that is welcome. Similarly, motility. I was talking to you about the moving sperms. So the lower limit is 42%, and you have to make sure that this much of motility is definitely there. A catch in this total limit is basically it includes the slowly moving sperms also. So we have to bifurcate and see how many of these 42% are actually actively moving sperms. Because when you're running a race, there's so many sperms are running to catch the egg, and if you're running a race, the fastest wins. So therefore, the fast speed or the highly active sperms are the ones who are actually going to fertilize the egg, and that fraction should be about 30% or above. Only then it is a good viable sperm sample. And then again, the normal limits, the normal forms, that means the shape of the sperm should be normal. And that is basically the lower limit for that is 4%, anything below. So imagine out of so many millions, if you have about 4 million, about 4% normal sperms, then it is all right. You should not get worried. If it is 1% also, if you may not conceive naturally with 1% or 2%. This is basically semen parameters for a normal conception. So if you don't have this, or the person concerned doesn't have it, has a very low normal, that means 1% or 2%, you should not worry, because those are the cases where you may have to resort to IVF, and you may not as a couple conceive if with natural methods. So this is something that was ignored for a very long time, but now, since we are getting to know more about male factor, we are getting into it, and that is why the research in male factor was also less, and that is the reason we need to now concentrate more on that, because male factor is a very major factor. Now let us come to the myths. Let us come to the common questions that arise in your minds when you're talking about this, and when we want to know what has happened. The first thing that a patient comes and asks us is it going to work, madam? Am I going to have a pregnancy? Does it always work? So again, if I come back to nature, if 100 women have a contact every month, those 100 are not going to conceive every month. Out of those, only 30% are going to conceive. That is the natural pregnancy rate. Every egg cannot give rise to a pregnancy. This is something that we all have to understand very well. Every egg can give rise to a menstrual period, but every egg cannot give rise to a pregnancy. That is something that we all have to understand. And the same happens in IVF as well. Every gamete, that means egg or sperm, is able to perform its function, but it may not be able to give rise to a pregnancy. So if you look at this data is actually from the American Society. SART is the American Society for Assisted Reproduction. It is their registry. We do not have a registry yet. It has just begun. This, we are filling in the first part now. We filled in we were supposed to fill in till June, but that has been extended till August. So all the IVF centers across the country are now filling in our details, and next year maybe we'll come back to you with much better data from our own registry. However, till then, it says that if the woman is less than 35, there is a 50% chance of her having a live birth per embryo transfer. Similarly, 35 to 37 is 37%, then 25%. You can see how it is decreasing. And when you are 43, then it is only 5%. Now, this 43 accounts for plus 5, which means 5 and 3 is 48. And in a 48-year-old woman with her own eggs, these are own oocytes, own eggs, there is only a 5% pregnancy rate in the West. In us, it is only 1% or 2%, because this age is very, very high for our patients. We do not expect too much of pregnancy rate after age 40, 41, which, according to what I told you, 5 years you add to whatever I say. If she is 41, then the data that you're seeing from the West, add five years to that. So if I'm saying this data of 35, then if it is Indian data, it will be 35 plus 5, 40. So naturally, the pregnancy rate will be about 25%. Remember that. So that is why we have to have our own data, our own analysis, and we shall come to it also. But of course, what is happening is, again, what we want to tell you today is that after age 35, the pregnancy rate falls drastically, whether it is a white woman or it is an Indian woman. So basically, we need to understand always, whenever we are going to a fertility clinic, what is their rate of success per cycle, per transfer, what is it that they are going to tell you. That is important. The other myth, which is very, very common, is IVF is unsafe. The drugs and the procedure may carry a serious risk in terms of risk to the baby, risk to the mother. And here, if I tell you that basically the risk is not at all serious. In 1 to 2% patients, there may be a drug problem which can result in severe hyperstimulation. OHSS is ovarian hyperstimulation syndrome, which is basically a problem which occurs when you have too many eggs. And that is now something which we are very, very careful about. This is very rare, 1 to 2%. Literally, it is even less than that. Moderate to severe, 1.6%. Again, these are WHO or American data, but again, our data is nearly the same. And if it is basically severe OHSS with when we are talking about protocols, then there are different protocols which give different types of OHSS. But what you need to understand is that even this 1.6% is high. We have very, very low OHSS rate in our clinics these days. Mild ovarian hyperstimulation is no risk at all because it is an OPD managed condition and it settles down in about a week's time. It settles down in a week's time. So that is what it is. Am I audible to everybody? There was a phone call. Am I audible?
Yes, ma'am, you're audible.
Okay. So then, what about the female problem? Oh. All right. So now, as this, we had already said that the female is contributing to about 30 to 50% also towards infertility, whether it is a single problem or whether it is it is a joint problem. So but here, what we do is, if fertilization takes place in the laboratory, and we are saying that infertility is a female problem, but we have discussed in detail that infertility can be a male problem also. And here what we are doing is that when the sperm is weak, when it cannot walk or it cannot swim or it cannot run fast, in those cases what we are doing is we are actually injecting a sperm into the egg. And this is called intracytoplasmic sperm injection. The short form for that is ICSI. Basically, this is intracytoplasmics. This is the cytoplasm of the egg. This is the needle coming in with the sperm inside, and it leaves the sperm here inside the egg, and therefore then the fertilization takes place itself. And so the first part of the reproduction, that is the meeting of the sperm with the egg, is actually done by ourselves, by our scientists or embryologists as we call them, and they are actually doing this procedure. This is a very fine and very beautiful procedure which has to be done with a lot of experience, because you can damage the egg and you can damage the sperm also. So therefore, only people who are actually certified to do it are doing it, and others, if they do it, then the success rate is not very good. Therefore, it is extremely important now, because of the declining sperm factor also. That means the sperm counts are declining, the motility is bad. So in those cases, therefore, the male partner has to be suggested this kind of a procedure, wherein the ICSI is done in the lab. Also, another thing that you must remember, or you may have come across, many of you whose partners, or if they are also present over here, may be suffering, is that there is no sperm in the semen that they ejaculate. It is totally azoospermic. That is what we say, that no sperm is seen. Now, what do we do in those cases? We cannot say ki aap kisi aur ka le lo. We don't ask them to take a donor sperm directly. We do the procedure called sperm extraction. So therefore, in those patients, the male gynecologist or the andrologist, as we call them, that is the specialist who's dealing with male infertility, they come in and they extract the sperms either from the testes of the man or from a structure called the epididymis. So therefore, from any part of the male tract, the sperms are extracted. They are not ejaculated as would be done in these cases, but they are actually taken out from there. And then again, the same procedure is done, that is ICSI. We do it on the ejaculate, on the extracted sperm, and then we achieve a fertilization as well as embryo formation. And again, the success rate of extracted and ejaculated sperms is the same. Very nice. It is the same and in both the cases. Now, the fourth important, this is actually should be the first one because this is something that everybody says. IVF is unaffordable, it is very expensive, and there is no public pathway. Well, this is what the data that ICMR shows, that Indian Council of Medical Research, and this is their parent body in Bombay. So they are estimating that the mean expenditure in IVF is 1.1 lakh per cycle in public hospitals and 2.3 lakhs in the private hospitals. And CGHS, on the other hand, those who are beneficiaries, in addition to that, other organizations are also giving a reimbursement. For example, ONGC and certain banks also, they are giving a reimbursement of 65,000 across fresh cycles, and this is basically subject to eligibility of the patient. Now remember this is very important for all of you to know that if in a public hospital, that means in a government hospital or any other public hospital, the minimum cost to the patient is 1.10 lakhs, which is actually not out of the it is out of the pocket of the patient. That means he has to spend on herself. Basically, then we cannot say that IVF can be done in 50,000 or 60,000 or what you see on the hoardings and on the advertisements given by certain IVF centers. So please be aware that actually there is a definite baseline cost of IVF because all the equipment and all the drugs are imported. Drugs, of course, we have started manufacturing ourselves, but the rest of the consumables are all imported. Hence, there is a cost to it, and 2.3 lakhs is the cost which you get in private hospitals. So this is what it is. Basically, need to understand that it is very important to have the right kind of knowledge about how much it is going to cost you and what exactly are your inclusions is this particular thing. So if somebody is saying that they are going to charge you 1.3 lakhs or 1.5 lakhs, you should ask them what is included in that. Are you including the procedure? Are you including the embryo freezing after that? What all are you including in that? And if you have to get a genetic testing also done for the embryo, is that also included or is it separate? So all this knowledge has to be, you must be aware of all this in order to know whether there is basically you're not getting confused or not getting some kind of a wrong information. But what I would like to stress again and again, that IVF in this country is not free. Whether it is in a government hospital, public hospital, or in a private hospital, there is a cost to it, and we all have to be very, very aware of it. The fifth myth, that is the fifth thing that people say कि हमें डॉक्टर ने कहा था बस आराम से, आपके अंदर कोई खराबी नहीं है, आप रिलैक्स कर सकते हो जाएगा. सो एंड स्पेशली इफ द पेशेंट इज यंग, 30 साल की लड़की है तो उसको कहेंगे हाँ ठीक है, IVF कराने की कोई ज़रूरत नहीं है या कुछ भी ट्रीटमेंट कराने की. माई सजेशन टू ऑल ऑफ यू इज हु आर लिसनिंग टू मी, डोंट रिलैक्स, जस्ट गेट योर ओवेरियन रिजर्व टेस्टिंग डन. मतलब आपको ये पता होना चाहिए कि आपके अंदर कितनी क्षमता है अभी प्रेगनेंसी होने की. यदि आप इस you have crossed that thing and your ovarian reserve has gone down, आपके अंदर अब क्षमता कम होती जा रही है, कुछ टेस्ट होते हैं जिससे हमें पता चल जाता है. So if that is there, then you cannot relax. You have to actually be very active about it and do it quickly, because otherwise you will miss the bus and you may not be able to have a child of your own genetic this thing, because basically now there are no eggs left. Similarly for the man, they will say okay, नहीं कोई ज़रूरत अभी नहीं है, we can test it later on, हम एक IUI कर लेते हैं या हम कोई और procedure कर लेते हैं. That is not correct. These two things have to be tested first, the reserve of the man and the reserve of the woman. If you are all right, you can relax if you are young. If you're old, say above 35 or something like that, then you have no time to relax also, because the time is running away and our fertility index, like I showed you, is definitely going down. So you have to take a call immediately. So this is what Please don't go by this how just relax kind of a thing. It varies from patient to patient. Yes, you can relax, I don't say that you can't, but then there is a rider to it. You first have to get tested, get a proper consultation, and then relax. So, what happens during an IVF cycle clinically? First of all, there is ovarian stimulation. When we call the patient on the first or second day of the period, and we start giving them some injections. And then after that, once the eggs are ready, once the follicles, as we call them, and we see them on ultrasound, once they are ready, then we give them an injection, which is called in our own language, it is called a trigger, which is meant to rupture the eggs, but we don't let them get ruptured. Before that, we take them out, we suck them out from the ovary. This is a very simple procedure which is done in about 15 minutes. Then the rest of these procedures are taking place in the lab. Fertilization takes place in the lab. Either it is conventional IVF or ICSI, like I told you. And then the embryos are kept in the lab for about 5 days. From first to 5 day, they are kept in the lab. And after that, on the fifth day, we are generally transferring them, because day 5 embryo transfer gives a much better pregnancy rate than day 3. But of course, in selected cases, we may have to transfer the embryos also on day 3 of their growth. So this part is up to this part, it is happening in the lab. Then again, we once the transfer has taken place, which we are doing in the OTs, again a very small procedure without anesthesia. It is not at all painful. And then we tell the patient to take some medicine which is known as the luteal support, and then do a pregnancy test after 14 days. So this total cycle is about 17 days. 12 plus 5 is about 17, and that is when one IVF cycle. Now, this has been diagrammatically shown how the embryos develop during this period. Like I told you, day 0, this is the egg, which is the unfertilized egg with a single nucleus in it. And then when it starts dividing, when the sperm penetrates into the egg, then there are two nuclei inside it, and also it starts to divide and forms two cells. And then on second day, this division continues to happen, and you have a 4-cell embryo. And then on a day 3, you have an 8 to 10-cell embryo. And then finally, what happens is all these cells start merging together. They form something which is called a morula. If you are science students, you would have read this in your zoology also. It forms a morula. And then on day 5, it further develops into something which is called a blastocyst, which has cells around it and a cavity inside it from which the whole baby develops. So these are basic steps of embryo development. And vitrification is a process wherein we can freeze these eggs. The eggs can be frozen and the embryos can be frozen at any stage, but generally we freeze day 3 embryos or day 5 embryos, because we have to use them later on for a subsequent transfer. So that is how we are looking at the embryology. Most importantly, what you need to understand is what are the indications. When should you go to a specialist? That is very important, because many a times we find that patients have lost so much of precious time with waiting with the GP or with somebody who is not such a specialist, and therefore when they come to us, we find that they are actually gone beyond the age of reproduction, or they are not going to conceive with their own eggs. So therefore, very, very important, female age under 35. If after 12 months of irregular unprotected intercourse also you don't get a pregnancy. In women between 35 to 39, if you've recently got married and you're between 35 and 39, after 6 months of intercourse, if you are still not able to conceive, please go and see a specialist. After 40 years or over, refer at presentation. Whenever you get married, first of all, get yourself checked and get it with. There should be no delay at all. Again, if there is very scanty period or no period at all, please refer to a specialist. If you are actually a patient of endometriosis, PCO, tubal disease, prior pelvic surgery, you should go to a specialist early, because as if you're going to take long, your disease will progress, and that actually complicates the treatment. You will be better off if you go to a specialist as early as possible. Similarly, abnormal semen parameters, or before any kind of male genital tract surgery, you must see somebody so that you have a proper assessment of the sperm also, and then you don't lose any time in your journey of reproduction. So therefore, early referral and to the right person is the most important thing, which helps you in getting your achievable outcomes. IVF is also not the only option, like I said right in the beginning, and we actually have many other things which we can do. For instance, if the patient is having just an ovulatory problem, she's not ovulating, otherwise she's normal, her age is also okay, ovarian reserve is fine. And this is a case of infertility, which is have no eggs. And here, most common condition is PCOS. So what we do is generally we give some tablets like letrozole or clomiphene. Some of you might be knowing it, and then do an ultrasound monitoring, and that's it. The next step would be intrauterine insemination, because basically, if it is not helping, timed intercourse is not helping, then we do something called intrauterine insemination, where basically you're just putting in the sperm into the vagina, into the tract of the woman, so that basically not we are crossing the vagina, sorry, we are putting it in the uterus, so that we can have a better pregnancy rate. The indications for this are mild male factor, unexplained infertility, cervical factor. So a prepared sperm is placed into the uterus around the time of ovulation, so that the pregnancy rate is enhanced. Again, IVF and ICSI are nearly the same story, just a little bit of difference in the procedure in the lab. A tubal factor, severe male factor, failed prior therapy, advanced stage. So practically all patients of infertility can undergo IVF if they have failed either in ovulation induction or in intrauterine insemination, or directly if the tube is blocked, or there is a severe male factor, or there is a failure of advanced therapy, like I said, and advanced age. So here basically we told you the steps. ICSI is done for severe male factor, or basically if on IVF we find that no embryos are formed, then there can be something wrong with the male, and hence we resort to ICSI. Surgical management has to be done for fibroid, endometriosis, etc. This restores the fertility to its optimum that we can do, and then after that you can choose any of the methods, whatever will be applicable to that couple. A little bit about what is happening in the country regarding the legal protection or the medical legal issues that are arising out of ART. There is an act which was passed by the government in 2021. This is called the ART Regulation Act, and it was implemented in 2022. And so therefore, under this, you have to understand that there are ART clinics which are registered with the government, and there is ART banks which are registered with the government, and surrogacy clinics also which are registered with those. These are the three entities that fall under this act: the ART clinics, the ART banks, and the surrogacy clinics, which are separate. So the separate registration, they may be the same ART clinic, may be also a surrogacy clinic, but there is a separate registration for that. So all these clinics have to be registered with the government, and they have to now, as I told you, we have the registry in place. So we have to every month send in our report of what we have done in our own clinic. Similarly, the very important part is donor regulation and also surrogacy regulation over here. So essentially, gamete donation, that means eggs and sperms, are actually the priority of the ART banks. These ART banks are actually specialized to source the sperm donors and the egg donors, and to supply the semen to the ART clinics. The ART banks are not taking out the eggs of the donors in their own centers. They are referring the the egg donors to the ART clinics, and the retrieval takes place in our clinics. Informed consent. Consent is very, very important, and all of you who are listening to this lecture must understand that please be careful of what you are signing and what exactly is the written consent over there, because this is very important for us from the medical legal point of view, that your consent should be proper and there should be no goof up in that. Then there are advertising restrictions made by the government, which says that you cannot do any sex selection advertising anywhere. And in addition to that, also the blatant advertisements about charges, etc., are not allowed. But nevertheless, we are finding that they are still there. Insurance provision, there is no insurance as such for infertility in the country. However, company insurances do cover them, and also this insurance is definitely mandatory for all egg donors, because it's a procedure which entails giving injections to the woman for 10 days and then extracting the eggs under anesthesia. Hence, donors have to be properly selected. They have to be insured so that they don't have any problem while we are using them later on. So that is mandatory, and that is a function of the ART clinic. Now, these are some of the questions which should be asked before you are giving your consent to a patient. This is how you will distinguish between a clinic which is actually telling you the truth, doing good work, and whose results are good. Otherwise, you will find so many things that have come up now, and unfortunately, all of them are not doing well. All of them are not so good. So you have to be very, very clever to really, really find out which are the ones which are doing well. So first of all, you will is this live birth rate? What is that means how many babies are born out of your clinic, out of this diagnosis that I have, out of the age that I have in my kind of a patient? What is the live birth rate of your clinic? Now here there is a catch as far as we are concerned in India, because many of our IVF clinics may not be able to give you the correct live birth rate, because this is something which they do not maintain. Why? Because after 3 months, we are generally handing over our patients to the obstetricians. And if we are vigilant and we actually are able to ask them what happened, how did our patient do, then yes, we will give you a correct live birth. But otherwise, this will not happen. Now, with the registry in place, this has become mandatory. And by the next year, or maybe 7, 8 months after this, you may be able to actually ask your doctor what is the live birth rate. Till date, what we are actually reporting, all the IVF clinics will tell you, is the clinical pregnancy rate, which means that once the pregnancy test is positive, how many of them reach the stage of ultrasound? That means, could you see the pregnancy on ultrasound or not? That is something that every clinic will tell you. At Nova, which is my own group of clinics, we are maintaining both the live birth rate and the clinical pregnancy rate. The clinical pregnancy rate for Nova across my 120 centers is about 58%, and the live birth rate is about 39 to 40%. So some of course some pregnancies are lost during the whole time of pregnancy, so the live birth rate is less. But these figures are very much in comparison. They compare very well with the Western standards. So we are quite happy with our national data. So what is that figure from your own audited data or a national average? I am talking about my own audited data. And of course, you have to ask this from the clinic you are visiting, because basically you are going to take their services. So you should know what is their average and what is it that they are offering to you. Which protocol do you propose and why? Now, this is again a question which some of you do ask already. You do ask this because you know a lot about IVF or infertility from Google, and therefore you ask what is going now. Antagonist protocols are somehow become the most popular ones. It is very rare to give the other protocols to our patients, but antagonists, because their OHSS rate is hardly anything, it is really that below 1% also. So all of us try to do most of the cycles using antagonists. Has my partner had a semen analysis for W21 standards? Yes, every clinic is now knowing that, and all of them do this kind of a thing. You should not worry about it. But see that the semen analysis is conducted in the IVF center, not from a path lab, because there the results are not according to the WHO standards. They are basically just pathological samples which are tested. So be careful about that. You will find that there is a lot of difference in the semen analysis when it is done from a IVF lab as compared to a normal standard path lab. What is included in the cost? This I have already alluded to earlier. You have to ask them whether it is medication, the process, freezing, etc., all that storage, whether it is included in the cost that they are quoting. And otherwise, you have to take a complete analysis. How many embryos will you transfer? Another major thing that has to be asked, basically, because single embryo transfer actually reduces the risk of multiple pregnancy and the cost of a twin pregnancy once you are carrying twins, because preterm nurseries can cause a little bit of a problem as far as as far as charges are concerned. But then in India, nobody is actually giving us any respite in IVF. So therefore, many patients will say, "हमें दो transfer कर दो," because we want our family to be completed in one go only. हमें एक नहीं चाहिए. The government also allows up to 2 embryos that can be transferred, and if the woman is of a higher age, then even 3 can be transferred. Especially if we are transferring day 3 embryos, not day 5. Blastocyst, no, never. Only up to two blastocysts. What are my alternatives before proceeding to IVF? I have already alluded to this. Ovulation induction and IUI can be done, but of course, it will depend on what you are, what is your problem, how much of it can lead to a pregnancy. So now, thank you very much for being with and showing this kind of a patience over here. I'm now handing this over to Dr. Ratna, basically to ask whether you have questions, and then we can both of us, or maybe I can ask you, tell you something about what you want to ask me. So it is very, very important to interpret your own test results. So don't feel shy of asking anything between to us today. And it is very important for all of you to understand what you are actually looking at. So thank you very much once again. And so the takeaways today are: infertility is a disease because it is classified by WHO. Male factor is definitely there in roughly half of our patients. Age is the strongest variable that you have to be very careful about. OHSS risk is largely modifiable and not a risk at all. Stress does not cause treatment failure, because basically stress is in all kinds of disease, not just IVF. And you have to take statutory precautions and protections, because the ART regulation law actually binds the IVF centers, and you definitely can ask them many questions on that note. So with that, I take leave of you, and I'm handing this over to Dr. Ratna now for
Thank
question and answers. And I'm just stopping to share my slides. Thank you very much once again.
Thank you, ma'am. Thank you. That was very educational. You threw a lot of light around the age factor and how the increasing age would reduce your chances to fertility. But I keep getting a lot of questions from patients who are on, say, some autoimmune conditions and therefore not able to conceive, patients on HIV drugs who are not able to conceive. Young patients nowadays, you see lung cancer and therefore taking chemotherapy and therefore not able to conceive. So is the process for them different? How are those patients supposed to approach the fertility problem? Are they supposed to talk before their treatment starts or after their treatment? Because many of them don't even think about it. It's only after treatment is over that they realize that because of the therapy that they have taken, they are not able to conceive anymore.
Thank you. That's a very important and valid question that you have raised, point that you have raised. Again, on one side, you have the age catching up, and on the other side, you have these problems. Let me first take the infections, HIV, etc. Now, again, in HIV, if it is a woman, then we are a little more scared than the man. But of course, both of them are equally important for us. We must know that whether they are on the ART therapy or not, whether their viral load is negligible or negative, especially if it is a woman, because she also has to carry on with the pregnancy. But discordant couples are also there, and so therefore we have to deal with all of them. The first point that all of you have to understand is that HIV is not it's not a contraindication to any IVF procedure. Just as all HIV patients are also delivered in our hospital, similarly we are also taking up all HIV patients for IVF or any other infertility procedure. But of course, the consent forms are different, and they are definitely mentioning that this is the risk to you. And so you have to be aware of this risk of having the baby getting the transmission, even after we are taking the utmost precautions. So because basically our sperm washing methods are wonderful, because we are trying our utmost that the viral load is completely negated over there. Still, there can be a possibility that the child may be affected. Again, if the mother is having the infection, she has to be very careful that she's negative. Otherwise, there is every possibility that the child is going to be. So that has to be clearly explained to them. Otherwise, there is no risk. The other major infection is hepatitis. Again,
Yes.
hepatitis B is another problem which we face and we find. again, the same thing. It is a contagious disease. The health workers also have to take precautions. So the adequate precautions, sanitization, etc., in the IVF lab and in the theater is maintained. And then again, once we find that the viral load is not there, and the hepatologist has cleared the person for a procedure like ours, then we take them up. There is no risk and there is no contraindication to it. If the embryo transfer has to be deferred, for instance, in the IVF, sorry, in the HIV patient or in the hepatitis patient, the sperms or the eggs or the embryos have to be stored in a separate container,
Yes.
which doesn't have any other material,
Yeah.
because there is risk of contamination to the others as well. So these are some
Yes.
of the broad outline of what we do. The third one was cancer. Now, in cancer, what happens is there is a beautiful procedure for all of us, and everybody should avail of it. Every patient whom you know must know that we have a huge program called fertility preservation in the country. And I am very proud to say that Nova has been doing it for the last 7, 8 years now. We are preserving the oocytes, we are preserving the sperms, we are preserving the embryos of any patient who is going through any kind of treatment for cancer. So before the treatment for cancer is started, they have to come to us, and we have to do the procedure of taking out their eggs and preserving it. If she's married, then preserving their embryos. If the man is young, semen preservation. So all these procedures are available, even to the extent that ovarian tissue is also cryopreserved, and the testicular tissue is also cryopreserved if the tumor is such or the cancer is such that we have to or the time is very short between the treatment that the patient has to take and our procedure. Because you know that this procedure of egg collection is going to take about 12 days, and if she doesn't have 12 to 15 days between the time of chemotherapy and her IVF, then we do an ovarian tissue cryopreservation. So these are some of the indications for these things. Autoimmune disease is a difficult problem, and autoimmune again has a challenge, because again, when some autoimmune diseases get better with pregnancy, we all know that, and some become up, they are up,
Yeah. Was.
yeah, they become worse. So the ones, if she's suffering from, say, MS or SLE or something which is going to get worse with pregnancy, in such cases, what we do is, when we are very much in touch with the doctor who's treating them, the immunologist, and once she's in regression or he is in regression, that they stop the drug which is offending for IVF for us. And once she's in regression, then quickly we try to do the same thing. We preserve the gametes or the embryos, and then the transfer can take place later on when the patient is much more settled. If the doctor says that she's got no chance of settling at all, then the option of surrogacy is available. That
Yeah.
so therefore there is hope for every kind of patient, I would say. It is such a beautiful science of reproduction that every patient, I think, at the end of it, only 1 or 2% patients will be left where we cannot give them any help, but otherwise we can help everybody. So that is something, that is the beauty of assisted reproduction. Yeah.
Thank you. And one of the biggest myths that exists in women, even educated ones, is that if you're having regular periods, your fertility is fine. So is that normal? Is that correct? Or is that, I mean, people need to know more.
Yeah, again, by and large, yes, they are right in saying that, basically, if the periods are all right, you're all right. But that is not true for all cases, because there are so many diseases where you may have a normal period and it's not just related to the period. You know that
Yes.
there are other factors also which are leading to infertility. The uterus may be producing a period, but it has a fibroid inside over there, which is not going to let the embryo implant in the uterus. Or the tubes are blocked and she may be having normal periods, so what? But she's not conceiving because of that. So the
Yeah.
patient has to understand that she has to get herself investigated before she really decides that this patient, I'm perfectly fine. So essentially, once you get married and 1 year into your marriage you are not having a child, please think seriously with your antenna up that something is wrong. Get yourself
Yeah.
investigated. If everything is right, then there is no worry. You can wait. It will happen. But of course, if there is a problem, you have to face it and to have to take treatment for it, just as we take treatment for any other thing. right?
True. Another myth or misconception that exists is the more expensive the center, the better the quality of treatment. You did allude to the actual cost, but this is really not true. That
This
if
is
you are very expensive, then it is the best IVF center. That's not
absolutely.
true.
Well, they should relate it to all the other branches of science as well, isn't of medicine as well. I mean, it's not that the best hospital is the one which is the richest, which is the most expensive. Even the
Yes.
ones who are moderate and they have a moderate kind of a expense, they are also doing extremely well. It's not that. It's the doctor behind the whole thing that is important, not the charges. I think
Yeah.
like we pointed out, you have to look at this, you have to look at this. So the whole picture has to come has to be taken in totality before you decide what is best for you. Just don't go by the chart, just don't go by the fancy place or something. The most important thing is cleanliness. That is important, even if it is a moderate kind of a place where they don't have anything fancy, but they are very clean, and you find that the nurses are also spick and span, everything is in order, their protocols are in place, then it is a good center. Their pregnancy rate is, of course, nobody can know whether they're telling the truth,
Yeah.
because that is the biggest problem in our country. However, whatever you can judge from the patients, from people who are sitting there, you will be able to know whether this center is doing well or not. Like, I mean, I'm not boasting about my own place, my own centers. We are not the extravagant kind of centers, but we are for the upper middle class. But of course, we
Yes.
cater to the tier 2 and tier 3 cities also. We are in the rural belts also. But the standard is the same, whether it is in Delhi,
Yeah.
Mumbai, or it is in Gorakhpur, or it is in even more remote places over there. Because basically, if the patient enters and he finds that everything is what I expected, then you have won the battle. But if you find
Yeah.
then the patient enters and there is confusion, I get patients where they are saying, "Madam, we had to wait for about five hours," and we are,
Yeah.
that is another thing that has to be managed. So the management has to be strong. So these are the things that will matter, and this helps in quality control. So something that all of us are learning. And if we are a big chain, that is the advantage of having a big chain, because then okay, this person is doing better than this person, and that what is wrong? Why is she not
Yeah.
doing well? You can easily, like, I'm the mentor, so I'm in charge of auditing every month. I audit my centers, and so I know which is my best center and which is the center which needs a little bit of hand holding. So that is
Yeah.
important for all of us to understand.
So in movies, sometimes they show that you conceive naturally after you are told that you can't conceive and you had an IVF procedure. So what are the chances for that, and how does that happen?
That is basically, Dr. Ratna, something that I have also learned. Never tell the patient that she can't conceive naturally. Every
Yeah.
patient can conceive, because that factor of stress is so high in any patient, especially in our country where this is a social stigma. This is not so much as a disease, but it's a social stigma. So for her, it's very difficult for anybody to bifurcate or separate your stress from your disease entity. It's very
Yeah.
difficult. So when you have something, you keep on thinking about whether you have hypertension or you have diabetes, you are stressed. So
Yes.
so for infertility, they are stressed. And once when they have done IVF also, they have done everything. And then they say, okay, अब मैंने तो सब कुछ कर लिया, कुछ नहीं हुआ, ठीक है, होगा होगा, they conceive. Because that stress from their mind is gone. They have done everything, to hell with it now. That is the attitude. And hence they conceive. And the other
Okay.
patients are also there, where they come to us, and once we tell them, okay, now you have this much time, will give you medicine, take this time and come back to us if you don't conceive, they also come back pregnant, because they are again relaxed. So for
Yeah.
these patients who are conceiving on their own, when they are coming to us for treatment, they are the ones who are actually managing their stress very well, I would say, and so they conceive. So also that. And secondly, I would also want to point out something which we also see very often. Patient does an IVF with us. We do the egg retrieval, and she's waiting for her embryo transfer. In the meantime, she conceives. After the egg
Uh,
retrieval, she is waiting and then she conceives. So here, some amount of scientific evidence also is in play, where when we are pricking the ovary, we are actually causing stimulation of the ovary, and it
mm,
starts to cause ovulation, starts ovulating. So an ovary which was not ovulating earlier starts ovulating with that pricking only. And hence, subsequently on her own, she conceives. So therefore,
Yeah.
there are many patients where they are waiting or they have not yet got the embryo transfer done, but they are. So their embryos are lying with us. They've already completed the surgeries. So it's very.
There's 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 another very big myth that children born out of IVF are smarter than children with natural conception. Is that true?
Both yes and no. Both yes and no. Because basically, there are studies to say that yes, children born out of IVF are also having problems. But I would say, you see that the this logic given logic to this theory is that they are better than the others. Is that the most of the children born through IVF are through cesarean sections, elective cesarean. Very few are born through normal delivery. So the ones who are born through elective cesarean, even if there are not IVF patients, their children are better than the normal vaginal deliveries because the child does not have to go through the stress of the birth canal. The brain or the head, that is the reason given for it. I do not know how
Okay.
true it is, but that is what
Yeah.
they say, that it goes through labor 12 hours, 14 hours in that whole thing, and that is what causes a problem with the brain, some oxygen deprivation, etc., etc., which may lead to problems. But
Okay.
on the other hand, they say that the process of IVF also causes a problem with the babies. Again, a myth. That is not true. Because when a patient comes to us and she needs an IVF, then she inherently has a problem. You cannot separate that problem from her body when she becomes pregnant. Suppose
Mm.
she has endometriosis or suppose she has PCOS, she will continue to have that problem and hence the complications of that problem during pregnancy. So those are
Yeah.
the ones that, suppose the patient is having diabetes, she will continue to have diabetes during pregnancy and therefore the child is going to, the pregnancy will be affected. So it is both ways. So I feel that, the children are smarter. IVF, I mean, I see from my own patient pool, very smart children doing very well in life. So people should not feel scared that their child is going to be abnormal after an IVF. No, it's not like that. On the contrary, children are very smart.
Oh, that's good to know.
Yes.
Then there's another fear or misconception that when you do an IVF, you will never get a single pregnancy. It is always either a twin pregnancy or a triplet pregnancy. Is that true?
I did allude to that. If a clinic is going to put in 5 embryos, they are definitely going to have a multi.
Yes.
Earlier days, when we did not have freezing in the earlier days, we also used to feel very, we used to be very heroic about it, enthusiastic about it कि अब pregnancy तो चाहिए ही चाहिए, तो हम जितने embryo होते थे डाल देते थे instead of wasting. And then it used to end up in multiple pregnancies, triplets and twins, etc., etc. But it's not true now. We don't do that.
Ah,
Most of the clinics are abiding by the rules, and especially Nova, we never transfer 3 embryos. It's always either 2 or 1. And especially if it is a blastocyst, in Nova, we are doing completely blastocyst transfer, day 5 transfers. Only in very few cases we are doing day 3. But in these patients, what happens is that they generally we are doing only one single embryo. But sometimes the patient herself insists कि नहीं मुझे तो 2 ही कराने, because she's had so many failures.
yeah,
Come to
yeah.
us with failures, and then they say कि please improve our chances and please we want in one more chance only. We are fed up of IVF. So those cases, yes, there is a chance of having twins, and of course, these are not coming from the same egg. They are different eggs, no. So they are not
Yes, yes.
identical twins. They are not identical. Majority of these twins are non-identical twins. Sometimes you do get identical twins also when you transfer a single embryo and that splits inside the womb. Sometimes embryos split inside the uterus, and that gives rise to a identical twin pregnancy. So that also happens. That can happen.
And another very big question that most patients ask us is how many times, how many cycles can we try for IVF? There seems to be a lot of myths and misconception कि 5 तक कर सकते हैं, 7 तक कर सकते हैं. So what is a good answer for that?
See, Ratna, the problem is that there are many areas which are still dark and we have no information as to why this happened. That is what happens when the patient fails. She comes and asks you, मेरा क्यों नहीं हुआ, मेरी प्रेगनेंसी क्यों नहीं हुए? Many times we know the answer and we tell them frankly, उनके embryo ठीक नहीं थे, egg ठीक नहीं, whatever. And so we tell them. But there are many who are unexplained and we really do not know what is the cause for them. Those are the ones who are going from one clinic to another getting IVFs done. But
Yes.
what I find is that as science is advancing, like I said earlier, also about 90% of the cases we know what is the cause and we can actually define it. And so,
Mm.
therefore, my advice to patients is you should be very selective in your IVF center with your IVF. Don't go to don't go to centers which are only advertising for the prices. The price is not so important, the quality is more important. And the first question, Dr. Ratna, you had put is, what is the live birth rate? What is your what is your clinical pregnancy? That is the most important thing, because basically we have to understand that this is a science which is still not perfect. Even nature is not perfect, like I said, but definitely we are trying to move towards perfection. Number of IVF cycles. Now, again, if she's going on doing it from a center which is not so good, suppose they don't have an embryologist. Embryologist is coming from some far off
Yeah.
and staying only for 2 days and going away. Embryos पता नहीं कैसे बने हैं, क्या हुआ है. So those are the patients who go on doing it again and again and again. And
Yeah.
then there are true patients, real tough cases where even in the best clinics they keep on repeating and yet they do not get a
Mm.
pregnancy. So it's a both way kind of a thing, but there is no hard and fast rule as to how many you should do. What is the upper limit? If you can take a wild guess, tell me how many would I have seen in a patient in my career? In my career, I
I
had
have no idea. Yeah.
7 to 8 is common. 7 to 8 IVF cycles is common. But this woman was amazed. I was amazed and I fell from my chair when she said 23 IVF cycles.
My goodness.
23. How could I make her pregnant? I couldn't. I just couldn't.
Yeah.
There was something with inherently wrong with her. She was a post cancer patient, so I'm sure the ovaries were affected, the eggs were,
Yeah.
and because of her religion she couldn't take donor eggs, so we knew the reason, but she was just going on and on. There was not
Yeah.
no closure. So sometimes what happens is patient, when they don't know the reason why they are not conceiving, that closure doesn't happen in their minds.
Yeah.
They say कि नहीं मेरा तो अभी हो जाएगा, बात ज्योतिषी ने कहा है, उसने कहा है, डॉक्टर ने कहा है. So so that is the very sad situation, because no matter how much you try to tell them कि भाई यहाँ पे अब नहीं होने वाला, वो नहीं मानते. So even with me, 24th cycle, she didn't conceive. She didn't.
Yeah.
Because basically, वही बात है ना, she was a cancer patient, post cancer therapy, and we knew that it is not going to happen, but she wouldn't listen. So there are these
Yeah.
patients also. But
And last question. I have taken a lot of your time.
no,
But
no.
there is this also this misconception, and especially with a lot of women now coming into the workforce, there's a lot of they take oral contraceptive pills and other measures for managing their cycles
Uh-huh.
because of work-related stress or travel, etc. Now, this misconception is that if you take these oral contraceptive pills for a very long time, then it affects your fertility and you will have to then go for IVF or other fertility treatments. Is that true?
Yes and no. Again, it depends on for see now. After all, these are hormones. If you are
Yeah.
going to take them without any reason, without any real indication, then yes, it can cause side effects, definitely. But
Okay.
if it is being given to you for a specific reason, then you no matter what you have there's no choice. You have to take it. So you have to take it. It's something like taking the Eltroxin for thyroid. You have to take it. You have to take it. There may be side effects. There may not be side effects. So also with oral contraceptives. But by and large, no. Oral contraceptives do not affect fertility if you are taking it. When you are taking it, it should not be at a stretch like 2 3 years completely continuously. What I keep telling and what majority of us tell our patients is take a break. Take 5 months or 6 months, then give a break of 1 month or 2 months, then take it again. 1 month of stopping of contraceptives is not going to affect your condition, so you can break your this thing and then restart again. If they do it like that, then the side effects and decrease in fertility does not happen. What was
Yeah.
happening in the past, it is a past story again. that when we started using oral contraceptives initially for infertility, people were taking it at a stretch for about 2 years, 3 years, like that, and that suppressed the ovaries completely. It stopped producing eggs, and then to revive that ovary would take another 2 3 years, or maybe 5 years,
Yeah.
and the patient in that period of time would become old. Hence, her ovarian reserve would go. So, therefore, then ultimately she is not going to have a baby. So, that is how the circle went initially. When we got to know that this is the action of they suppress the ovaries completely, now we do not allow patients to take them at a stretch unless she doesn't want children. If she
Yeah.
wants children, no. But periods, yes, it can suppress the periods, especially in
Thank you,
patients
ma'am.
with endometriosis.
Yeah.
We do give them for a long time, and in those cases, we want the periods to be suppressed, but the fertility is affected. So, therefore,
Yeah.
it has to be taken with a pinch of salt and carefully. Every medicine has a side effect. You have to be careful what it does and take it according to that. That's it.
Thank you, ma'am. This was brilliant session. Thank you so much. I'm
Thank you,
sure
everyone.
our audience will want to listen much more, to, from you, and we will
Thank
look at the opportunity of how we can invite you back. I'll
thank
hand over to
you.
Rashika to thank you formally
Before I
for this
leave,
session
before
today.
I leave, I must repeat my tagline. This is something I tell every patient who comes to my center first time, that they have come to me for a desire, not a disease. Remember,
True, true, true.
they are absolutely hale and hearty, nothing wrong with them, but they have a desire to have a child. So it is they who have to tell us how far we have to go. We are not the ones who have to tell them, "कि IVF hona hai tumhara." They have to tell us whether they want it or not. So
Yeah,
I will only do what they require want us to do. हम उनके बिना तो कुछ नहीं. So their consent, their desire is most important. So thank you very much. It was
absolutely.
wonderful. I really
Thank you.
enjoyed this very much, and
Yes,
I just
ma'am.
thank you,
Thank you. Thank you. Thank you so much.
thank you.
Over to you, Rashika.
Yes, thank you so much, ma'am. All that we got to learn today, that was very invaluable of you, that you shared your expertise with us. I think we all kind of realized that how important timely medical guidance is, and how much of clinical facts and things that we don't know, that it's important to approach the right center and approach the right doctor and know about all of it before taking this big step. So I would like to thank you again, Dr. Sonia Malik, and I would like to thank all of our participants for joining us. And hopefully they got to learn and were empowered and informed, and this will help them in their IVF journeys.
Thank you so
Thank
much
you.
for
Thank you,
having
ma'am.
me. Thank you.
Thank you. Have a great weekend.
You too. Thank you so much.
Thank you. Thank you, ma'am. Thank you.